So we want to thank all the presenters for those excellent presentations. And so now there's going to be an opportunity for some questions and discussion with that excellent panel. So I guess we'll go ahead and we'll let, I'm assuming Echo, since we heard you on, that you'll be speaking for the Luke Commission, and I think Lydia, you'll be speaking for Care for AIDS, and then we would have Gibstar and Father Rick. So let's just, I'll go ahead and ask the question, and any of you who wants to speak would be able to. We've had several questions in French from DRC that thankfully, can I ask first of all of you who are on the panel to turn on your cameras, and hopefully we can get your pictures. I see Father Rick, I see Gibstar, Lydia, can you and Echo turn on your cameras, please? While they're getting going, I'm seeing, there we go. Hi, Echo. You're in the middle of taking care of patients today, aren't you? And hi, Lydia. So good to have you all. So one of the questions that we had, and would love to hear briefly from each of you, how have you been able to integrate HIV prevention and care into the COVID and TB platforms? Maybe how have you been, or how would you suggest that would be possible? And so any one of you ready to start, can go ahead.
Okay, yes. I think for us at Circle of Hope, we really picked up the parallels between HIV and COVID-19, such that when the quarantine instructions came from the government, because we already are embedded in the community, it was very easy to follow through with our people who are already taught to stay at home. Now, the home where they were taught to stay was already our outreach point. And therefore, in terms of looking out for TB and HIV, we use the same protocols of testing and screening for TB as we visited the clients and potential clients in their home settings. And in terms of COVID, of course, our community health workers were already protected through the uses of masks. And so we actually borrowed a lot from the successes of HIV in handling both TB and HIV.
Great, thank you so much.
I hope I got your question.
Yes, I think you did a great job. Echo, I see that you're unmuted, and Father Rick and Lydia, you want to go ahead and open your microphones too if you have something to add. Echo, go ahead.
I think taking care of patients when your platform is focused on compassion and comprehensive services, it just becomes one of the things that you do. I think one of the encouraging things is that people that come for COVID testing or end up being admitted on the COVID wards where we are, many of them have not tested for HIV and end up initiating on HIV or TB treatment while they're admitted or being treated for COVID. So it's another platform, it's another opportunity to engage with patients about comprehensive care. Yeah, it's been an exciting time, a very difficult and stretching time, but good. The challenges there's a lot of opportunities with the challenges.
Great, thanks so much. Lydia?
Yeah, for us at Care for AIDS as a community program, we just wanted to make sure that all our clients who are currently on care are not missing their medication. And therefore, we made plans to ensure that the community health workers were taking the medications home for our clients. That was number one, so that adherence remained at 100%. Number two, we provided masks for 100% of our clients, whether or not they had TB. So all our clients received masks together with all our staff. And then we provided hand washing areas. And we had center-specific days where we would review the clients who needed our support. So we are happy that we did that because none of them missed their medication during this lockdown period. We currently are back to work. At least we are able to see them twice a week. And we are seeing, we have actually retained 98% of our clients on care, despite the fact that we had COVID. So basically, that's what we did as an organization.
Great, thanks, Lydia. Father Rick, did you have something to add?
Yeah, just to add, again, as people have said, that we made sure that PPE was available both for our staff and those community health workers and faith leaders that needed it. We have some additional data since those slides, and during the COVID-19, especially the lockdown, the request for HIV self-testing skyrocketed, and we used targeted methods that we were still getting yields of 5 and 6% from during COVID. The key also is to make sure that the community is educated, that there's a balance between doing a targeted intervention of those most at risk so that you're not wasting this valuable resource, but also that you're not stigmatizing. And we found, because of the trust that these faith leaders had in the community, we were able to do that. So people that were afraid to come to any medical clinic because of COVID would come for, we could get a self-test kit to them. And then if they were reactive, assure them that we had decongested our clinics through some other interventions, and we could provide safe care in the middle of COVID.
Great, thank you so much. Okay, let me go ahead to one of the next important questions. If you wanted to give one or two key pieces of advice to some of the colleagues from other countries around the world about how they could take your program that has been successful and adapt it and implement it in another location, what would you say?
Can I start, Susan?
Sure, you're welcome to start, Give Star.
Thank you. I think the first thing really is the issue of revaluing the importance of relationships. The fight against HIV is one fight globally, and therefore there's no room for competition. So we need to go into a very serious mode of collaboration. And in talking about collaboration, it has to start with what do we have. In each country, there are contexts, but what is the underlying theme, which is similar, is the role of faith leaders across different religions. So the faith leaders do possess, like my previous colleagues have said, unique virtues and qualities that are needed everywhere. And one of those is an introduction of hope among clients and the communities. Secondly, the trust issue. Thirdly, the intricate local knowledge which the faith community has across countries is incredible. And they're the first to know of any serious situation in the home setting, be it clinical and social or psychological. So I think that the first thing is to establish robust, strong connections and relationships across sectors. I think that's the main thing I could say, Susan.
Thanks so much. It looks like, Lydia, you were ready to say something, were you?
Yes.
Go ahead.
I first and foremost want to appreciate the faith community's initiative. For us as Care for AIDS, we partner with local churches because we are a Christian organization. However, I want to bring to light that we take care of all clients, all manner of clients, whether or not they are Christians. We have been able to minister to Muslims, and through faith initiatives, we've been able to even sit down with one of the mosques in Nairobi. And just before COVID, we were going to go into a partnership so that we can have one of our center activities being held in one of the Muslim halls. So what I would emphasize is respect for sanctity of life, that we view each other with compassionate eyes, and just understand that we are all human beings with all our shortcomings, and embrace each other with love. This I have seen brings a lot of positive outcomes, especially because in 2019, 2020, we had a group of church hall and participate in the program. So overall, I would say that respecting our diversity, respecting our religions, will ultimately produce the results that we are looking forward to, and that is, reduction in new infections, and even suppression of viral loads. I want to say that introducing the male programs, produced the success that we have produced in terms of viral load suppression. I want to urge all of us to, just as Gipster has said, let's work towards building strong relationship with our communities without, any bias of any kind, and let's embrace our diversity, even, religious diversity.
Thanks, Lydia.
Thank you.
Thank you, Lydia. Lydia, the next time you comment, you're going to have to speak a little louder. We were losing you there at the end. Echo, I see you're not muted. You want to go ahead?
Sure. I think, just as both the speakers before have mentioned, that strong collaboration is, I think, one of the opportunities that's coming out of COVID. It's impossible to stand on our own now, and that's also increasing collaboration when it comes to HIV and TB treatment. So we're excited about that. And I think, just as the prior two speakers have said, compassion works for all of us, because the human piece is what's so important for patients to feel like they can uptake services that otherwise they would feel stigmatized by. So I don't think there's anything special really that we do except prioritize at the highest level a compassionate approach, and making sure that we first address what's most important to the patient, which may not be HIV and may not be TB, but if we can show compassion in those areas, it opens the door and allows us to have access to other areas. So I think the church obviously has that embedded in the approach to people, and that's why it's very helpful in being able to move into some of those areas where we've missed over the last 15 years. And so we're excited to see closing of those gaps and making sure that we don't lose any of the gains that we have been able to accomplish together in HIV and TB during this time. I think that making sure that we stay focused on both fronts is extremely important.
Thanks so much, Echo. And I would want to, right before you comment, Father Rick, I would just like to emphasize that one of the things I really appreciated about yesterday's different speakers and meditations and prayers is how clear it is that across faiths we have hope and compassion that really unites us. So I really am grateful for all of you who have tuned in, and that this is a unique quality that I think people of faith bring. So Father Rick, I know you well enough, and I actually know the rest of you on this call well enough as well, to make a comment about, as you're speaking to this replication in other OUs, I haven't really heard from Echo, Gibstar, or Lydia how caring for the staff is a priority. As you're thinking about replicating, caring for them so they are resilient and don't burn out. But I know that's a topic that you particularly emphasize. So perhaps while you're talking about replicating the HIV self-test in other venues, that's what people are really interested in. Maybe you could also at the same time address how you think that self-care, encouraging self-care plays into this. Thank you.
Well, yeah, absolutely. And Susan, I'm not going to talk technical on this response, because send me an email and I'll tell you all about HIV-ST. I will tell you real briefly Father Rick's 4 rules for successful programming. Number 1, spend time with God, however you understand that word or that concept. And if that's prayer, if that's meditation, if that's a walk in nature, we all as individuals have to renew and feed our own souls. However, your tradition or your non-religious tradition does that. That is absolutely key for everyone on this call, for us as leaders. Then, as Susan, as you said, number 2, you get that connection, you get the source of compassion to be compassionate. Then number 2, we take care of each other. Take care of that staff, because this is stressful times. We need to build resilience. Hopefully not everyone on the staff will be anxious the same day about getting infected with COVID, about all of the challenges that we're facing, finding men, finding children, welcoming key populations. We have to take care of each other. Then number 3, we take care of the patients. And as Dr. van der Waal said, we build on that compassion. We build on that vocation to be healers in a very broken world. Healers to people that need our service. We adapt that vocation of service. And rule number 4 is never reverse that order. Spend time with God, take care of each other, use our vocation to take care of the staff. Do not reverse that order. That's the way of sustainability. That's the way of building our programs. And if you want the technical information of HIV self-testing, send me an email.
Great, thanks, Father Rick. Okay, this next question is going to be for Lydia Gibstar and Father Rick. That's the first question, and then Echo, we have one specifically for you all on PrEP. But let's start with the first one. There was a lot of interest in several of the participants, particularly some from DRC, but beyond DRC, that we are really having a hard time retaining adolescents living with HIV in care and on treatment. And while I know, Lydia, that your programs tend to start 18 to 35, maybe you can even talk about just the 18 to 24-year-olds, the younger set. But how do you find that the models that you have been using are indeed effective for these adolescents and youth groups? And if so, can you talk about whether you had to modify the model in any way in order to, I think, Father Rick, for your case, it would be both find and retain. And Lydia, for your case, it would be the church centers and the mosque centers where you're trying to retain people who are not suppressed or living in extreme poverty. And Gibster, I think you may have missed it, but there was a particular interest in whether these models you've been talking about have been effective at retaining adolescents and youth living with HIV who were really having a hard time retaining on care and treatment. So anyone, Lydia, why don't you go ahead and start? I see your mic is open, and speak up a little bit because you were, the last several times you trailed off a little bit in the volume of your voice. Thanks.
Thank you, Susan. Am I audible enough?
Yes.
Can you hear me?
Yes, speak up, speak a little closer, a little louder, but yes, we can hear you.
Okay, so for Care for AIDS, as you have rightly put it, our interventions have been based on adults 18 years and above, all the way to 45 years. However, in 2018-2019, we also reduced our age group to 15 years because we wanted to understand the challenges that the youth face and how we could coin our program to be able to support them, be retained in care, and have suppressed viral loads. And I wish to report that for all the youth that we enrolled in our 2 programs, they were about 102, and 98% were not virally suppressed. When we listened to them, most of them had blames to their caregivers. You can't hear me? Can you hear me?
Yes, we can hear, yeah, we can hear you, yes. I'm just saying this is so shocking. So many of them were not virally suppressed. That's why I'm shaking my head. It's just so worrisome, but yes, we can hear you fine. Keep going.
Exactly. So when we talked to them, actually 80% of them already were in a relate to anyone. So most of them would not take their medication. They didn't have anyone to turn to, so they could not talk to their caregivers, neither could they talk to the healthcare workers, because one, at the hospital, you know, it's abstinence, and it's wrong to have sex, and so nobody offered them a reproductive a program that accommodated their time. We ended up seeing some of, and most of them over the holidays. And so by the end of 18 months program, we actually recorded 95% viral load suppression. and most of them wanted to refer their colleagues to our program. So I would say for that particular population of the youth and adolescents, we just need to give them a listening ear and just probably show them that we are here, we care for them, and that it's not their, it's not their making for them to be, HIV positive today. I want to encourage all of us, just as I said about LGBTI, if we can put a focus on our youth and, embrace them with their HIV status, with their tantrums, with their rejection of ARVs, just embrace them and show them love with a lot of compassion, we will ultimately see a lot of viral load suppression and reduction in new infection. As for the young mothers, most of them did not disclose their statuses to their partners. Therefore, they just went into relationships. They went ahead and got pregnant and got their babies without informing their partners. So disclosure rates were about 45%. But in the course of the program, that shot a bit high to 73%. And we realized that the contributing factor is fear. That if I share my status with my boyfriend or my partner, they will ultimately leave me. So they get into a relationship with the hope that by the end of their pregnancy, their partner would have, turned HIV positive. But again, because they are taking their medication, then the transmission rates are lower. And so they end up in this conduct relationship. But 60% of them remained in their relationship. However, 40% lost their relationships after disclosure. So again, I will reiterate the fact of all our clients with their, their different needs and their different presentations. That's all I have.
Great, thanks, Lydia. That's some fascinating data, and I think you have a lot to offer some of the other participants who would really like to learn from this model. Gibstar, what would you like to say?
Thank you so much, Susan. Yes, just to add to what my sister said, generally for our colleagues from DRC and others, most of Africa's demographics is similar. We have a very young citizenry across the African continent. And so most of the issues are very much similar. And so number one, what we have done under our engagement is to ensure that we balance the age mix of all the community health workers who are faith engaged working in the community posts. So we have a very nice healthy age mix. And secondly, we also balance the gender. For instance, for every one of our community posts, we have 2 females and 2 males as a minimum. And the youngest age is about 17. The oldest is 75. And so this is the first strategy. The second strategy is we've used a lot of social media in reaching out to young people. As you know, they're quite technological savvy. And so we use a lot of contacts to encourage them through messages on WhatsApp, Snapchat, and all these fancy social media platforms to ensure that those who are on treatment, we remind them and share a lot of information. Some of the information may not be related to HIV, but just to engage them and keep them occupied. Number 3, we do have among our community health workers an adolescent focal person. So in all the facilities, we have an adolescent focal person, and that becomes the champion to ensure that every single young adult living positively is looked after emotionally, spiritually, psychologically, and also vocationally. We do a lot of what we call support groups, focusing on career development and income. And lastly, but not least, we do provide a day we call the Youth Friendly Day, where all adolescents are encouraged once a month across all the plenty or many community posts we have across the country. Thank you so much.
Yeah, that's just excellent. Father Rick, what would you like to add?
I'll just add that we use I believe it's a CDC program, Susan, the Operation 000. So we have about 1,400 kids and children and adolescents on treatment, and we're running about 86 to 88% viral load suppression with excellent adherence. So the 3 zeros are 0 missed appointments, 0 missed doses, 0 viral load, and heroes are zeros. So that's our program. And, you know, the kids know this, and I walk into the clinic and they, yes, Father, I'm a 0. You know, because we've created that social expectation. We have staff that are trained to work with children and adolescents. That's number 1. And you pick the staff to train that like children. Not every doctor or nurse likes children. That's okay. Don't train them to work with children. Train the ones that like children and adolescents to build their skills. We've done an outstanding job about getting the optimal regimes, the medical, the ART, on our kids. And then we have a social worker that's working with the psychosocial and the spiritual issues. So there's been lots of questions on prayer and faith healing and ART, and that's part of almost every support group of how we can use both great ART, optimal regimes, and prayer as part of your treatment. This is a peer-led intervention that we have peer mentors who will mentor newly enrolled students, newly enrolled adolescents and children. We have mentor moms for that, you know, moms that have raised HIV positive children and can mentor new moms that have HIV positive children. So that peer aspect, as Gibstar said, that accounts for good quality physical and biomedical care, the psychosocial needs, the spiritual needs, that these kids feel belonging. And again, 0 missed appointments, 0 missed doses of medication, 0 viral loads. Heroes are zeros.
You know, that's really helpful, Father Rick. There's just 2 things I want to add before we get to the question for Echo. One is that there is a PEPFAR solution that you could called Operation 000, and anyone can read it and learn what it entails.
Aller sur Internet.
And additionally, beyond that, are you all still hearing me okay?
Est-ce que vous m'entendez encore bien?
Yes, okay, great. And additionally, beyond that, Father Rick, one of the things that really struck me when I first saw the Operation 000 data from Kenya, and you certainly seem to have, it seems like the country has scaled it quite successfully, is your emphasis on celebration, which I did not really hear in your description. If you could just say a few sentences about that before we go on to the next question, I think it would be helpful.
C'est quelque chose que je n'ai pas vraiment entendu dans votre
yeah, absolutely. So, you know, when you have a child, and especially when you have an adolescent that isn't virally suppressed, it is not wagging your finger in punishment at how awful you are. It's linking them with a peer who is virally suppressed. So we'll have a support meeting, and I was horrified because I'm from the US and a patient confidentiality, but we pass out the recent viral loads to all the kids. And we ask the highs to raise their hand. We ask the lows to raise their hand and link them together so they're providing not punitive, but celebrative, as you said, and supportive. How can you get to be a 0? And they can then support each other. Even now, my WhatsApp, you know, I'm trying to, some of the kids are listening to this right now, and they're on WhatsApp supporting each other and celebrating that they're a 0.
Great, thank you so much. Okay, Echo, on to you and this prep question. So we've had a lot of interest, and I think I might even say some surprise that you as a faith-based group have been able to succeed in getting a large number of young people or people who are HIV negative on PrEP. And so I think the question was, what are the challenges for religious leaders in accepting this first? And second, what motivates people of faith or faith leaders to say yes to this without including in it a lot of judgment? So if you can speak to that, it would be really helpful.
Okay, thanks a lot. I think what motivates faith leaders and motivates humans in general is understanding the big picture, understanding the goals. So in the trainings, we discussed a lot. What are our goals as a nation? What are our goals as a global community? And what is the big picture? And the big picture is that our communities are healthy, they get healthy, and they stay healthy. And so it has been interesting that when presented in light of the big picture and embedded in a full menu of services, there's not as much pushback as we would have expected from the faith leaders. Some of the early comments many years ago around condoms, you would expect there to be some of those same kind of pushback. But we had really good, open, transparent conversations during the trainings. We tried to make them more casual so that there would be that dialogue that needed to be there to break down some of the perceived barriers. It's been very interesting that through the FCI initiative, of course, outside of self-test, PrEP has been the biggest referral that we've gotten. And it's been really exciting to see the faith leaders and the faith community embrace interventions or approaches that probably would have been much more difficult in the past, and to see them seeing these interventions as part of the future and the way that we need to address and approach our communities. So I think the motivation is more around faith leaders understanding the big picture and where we're headed, what our goals are globally and nationally. And I can't say that this has been a huge challenge. It just hasn't. It's just been embedded in the full program.
That's really helpful. And I think an additional question is to, particularly as more and more data emerge on how common rape is and how common it is for girls and boys as well, more common for girls, but also more common for young boys than people are aware of, to have sexual activity forced upon them. I've wondered if that fact helps in any way persuade people of faith to be more open-minded and compassionate about this is really the best for anyone who could have any risk.
I do think there's more awareness, and there's been more intentional sensitization of faith communities, because there have been periods in our decade and a half in Eswatini where faith leaders would want to pretend those things are not happening. I do think that there's more awareness, there's been more intentional sensitization, which has really, really helped. The thing I love about PrEP is it puts the patient in control of those vulnerabilities, which are very difficult to eliminate from some of the communities. And so that's been one of the encouraging things about PrEP, is that people can say, I feel at risk and I want to protect myself. And allowing and building a space for people to be able to take control of their health and their future is really exciting.
That's great. Thank you so much. Okay. So this is going back to a question specifically for Father Rick. Have there been particular challenges that the faith leaders have had in offering HIV self-tests or disseminating them? I think you hinted at this with some of your statements about training, and clearly there were a couple of questions about this, so people are wanting to know a little bit more.
Sure, yeah. I mean, a couple things. One is before the lockdown, but hopefully we can get this going up again, training pastors in basic HIV is just critical. And so it was not only training in HIV self-testing, but just training in the really basic things. And I found this very true, especially for my brother Catholic pastors. oftentimes they were just left out. They have not been trained. And so when they feel ignorant, then they don't want to talk about that. So that's number one. So once we got the pastors trained, they may not be the one necessarily to bring or identify the person that needs an HIV self-test, but their health committees, the lay leaders in their parishes that go and visit the sick, know who's sick, knows the community, then the pastor supports those lay leader groups in the parishes that help us identify those most at risk. So it's training both the leadership of the local faith community as well as kind of the implementers, the boots on the ground people that are visiting the sick and know the sick.
We've had a couple of people ask for the email addresses of the presenters, and maybe you can just let Francesca know if it's okay with you to share those with people who are needing them. And Francesca, we've also had a couple people ask whether their slide presentations will be available. So maybe you can even place that in the chat. So I know you all well enough to know there's other things maybe that you would want to comment on that you didn't have time to comment on because of your short presentations. So I would love to hear from each of you. We have about 10 minutes left. I would love to hear from each of you, maybe a couple of minutes of something that you would really love to leave with our interfaith community around the world that you think has been key for the successes that you've experienced in the different programs that you've talked about. And the only qualifier I would add for ECHO is we don't know if you have any more data on the likelihood of being able to retain people on PrEP, but it sounds like you made some modifications in your program. We would love to hear a little bit more about this really important question going forward. So let's go ahead and start with Lydia. Do you want to start? Or give Star, your mic's open. Why don't you go ahead and start, and Lydia, you can be next.
Thank you, Susan. First and foremost, it's just to appreciate the work that UNAIDS, PEPFAR, CDC, USAID is doing with the faith community. And in our interactions, in our work, not only in Zambia, but in the few countries that we've replicated this model, we have received the same message from the clergy. They've been asking the HIV sector, where have you been? So we had left them behind for quite a number of years. And so we are pleased to report to the conference that currently we are working with about 1,000 clergy from the Christian and Muslim fraternities. And like Brother Rick and Echo said, we have been orienting them on the U equals U messaging. And that has transformed their perception of HIV amongst their membership, including things like rape and everything else. And so the issue of orienting, training, and mentorship of the clergy is key. Now, Susan, this is critical for the conference to hear. We also have redefined who constitute the essential workers in both COVID and HIV. We believe that because of the preventive side and the adherence side of HIV, the clergy across faiths are part of the essential workers. They are the ones who encourage people to stay on treatment and encourage the ones with fear to actually test and be linked to treatment. So we need the church, especially on the prevention side and the adherence side, which will lead to suppression. And lastly, but not least, Father Rick talked about the celebration. We have been doing this for quite a while. We celebrate the staff twice a year with all sorts of recognitions and awards. But beginning in 2020, we've included celebrating our donors, our faith leaders, our community local leaders with recognitions. As I said earlier, it's an incredible partnership that must be harnessed and really liberate together. So the issue of celebration has gone beyond the typical clinical health provider to include the church, and of course the Muslims as well, and also to include the donors themselves and other partners working in the same sector, so that we learn to affirm each other. Thank you very much.
Thanks so much.
Lastly, the reason why we need to use the church and the faith community, because we have this sense of mandate, this sense of calling that is our duty to do it, whether we are paid or not. Thank you so much.
Thanks so much. And I've just learned that I didn't realize there are some closing prayers for this session. So maybe each of you can take about a minute to add. And we have a little bit less time than I thought. Lydia, go ahead.
So for me, I would just talk about care for AIDS that is embracing body and soul.
A little bit louder, Lydia.
As a faith community. As a faith community, can you hear me now? As a faith-based organization, we work for both body and soul. And therefore, in the year 2018, we began working and
Sorry, Lydia, you're breaking up. We really can't hear you. Take a break for a second and go to Father Rick.
Private hospitals, government, most at need.
Okay, Father Rick, why don't we go ahead and go to you for just a minute if you have anything else, and then end up with echo. Sorry, Lydia, we just couldn't hear you. Go ahead, Father Rick.
Yeah, my 1 minute is to adapt what many medical schools do is by training their students with standardized patients. That's a nice way of saying role play. So if you're training your youth on how to support youth, if you're training people on how to elicit partners, if you're training staff on how to do screening for gender-based violence, you have to incorporate extensive role play, behavioral watching to see that your staff understands, practice again, bring up difficult cases, but don't just teach didactically. Use those behavioral, those behavioral role plays.
Skills building, great. And Echo, let's close out with you.
Hi. I think that on the retention piece, what we didn't understand at the beginning that we understand better now is that people want to be in control of their vulnerabilities. So when they're vulnerable or in a vulnerable relationship, they will be on PrEP. And when they do not feel vulnerable or step out of maybe those vulnerable spaces, they will want to stop PrEP. And they want that flexibility to be on and off when they feel like they're more vulnerable. So that's really been, we've actually just learned more about how people want to use PrEP to protect themselves in the case of the retention piece.
Great, that's helpful. Let me go ahead and turn it over to Francesca. And I really apologize. I did not quite understand that we still have like 10 or so minutes of the agenda. Go ahead, Francesca, and the organizers take it over. Thank you so much for an excellent session, all of the speakers.